Does anybody know anything about female sexuality? In my training, I was told women are difficult, they take too long, we'll never figure them out, and don't worry, the gynecologists are taking care of them anyways. It's a group of people who are already very comfortable discussing sexuality as important, valid healthcare.
If you've heard of the longevity Bible, Lifespan, by Professor David Sinclair, you know that living well is more important than just living long. In fact, this show is dedicated to the science of beauty, wellness, and longevity. That's why I'm so thrilled to partner with Melrose Future Lab. Future Lab is Australia's first supplement range focused on extending not just your lifespan, but your health span. Available exclusively at Chemist Warehouse, these affordable and science-backed supplements are the key to aging well. Welcome to Ageless Radiance Club, the podcast where we challenge outdated narratives and explore the science, beauty, and power of longevity. I'm Bahar Etmanen, and today we're exploring a topic that's often overlooked, dismissed, or shrouded in stigma: sexual longevity and desire in midlife and beyond. We're living longer than ever before. The average woman today can expect to live well into her 80s with decades of post-menopause sex life. And yet the messaging we receive about sexuality often suggests that desire dwindles, pleasure fades, and our sensual selves should quietly retire. Spoiler alert, that's not true. Joining me today is Dr. Kelly Casperson, a board-certified urologist, sexual medical expert, author of You Are Not Broken, and host of the podcast of the same name. On a recent trip to Australia to headline the So Hot Right Now event at the Sydney Opera House, the juggernaut of a women's health and menopause movement, Dr. Kelly brought down the house with her frank approach to sexual health and longevity. She has made it her mission to debunk myths about female pleasure, break down the science of sexual function, and empower women to reclaim their bodies, desire, and confidence at any stage of life. From hormonal challenges and GSM to the impact of mindset, medical treatments, and modern sexual wellness products, we'll cover what women need to know to have a thriving sex life, not just in their 20s, but in their 40s, 50s, 60s, and well beyond. Dr. Kelly Casperson, I am so delighted to welcome you to Ageless Radiance Club. Welcome to Australia and welcome to the show.
Thank you for having me.
Dr. Kelly, I've been listening to you for quite some time. You are a phenomenal educator. And I did not know that I needed a urologist in my life until I started listening to you. Where have you been all our lives?
Well, I'm a bit unusual because of, the specialty I'm in now. People say, so I just need to go to a urologist to get all this. And I'm like, not all urologists are trained exactly like I am.
No, they are not. I feel like you are the sex education fairy godmother that we have never had. And
Thank you.
Things that I have learnt from you, from your podcast, from your Instagram, is so mind-blowingly profound. And I think I was telling you earlier today, I was doing a long drive. I had my 14-year-old daughter in the car and we were listening to one of the episodes of your podcast, which is pretty spicy. And I thought, no, I'm not going to ask her to put her ears in while I listen to this episode. This is the education that I wish I'd started earlier. I wish I'd had these conversations with my daughter. And I love what you're doing. And I love how you've taken the role of urologist, understanding, the mechanics of the female anatomy, but then applied the social, the emotional, the psychological aspects of sexual wellness and health to your profession.
Thank you. I mean, it started, I was just a regular urologist, and then the 7-year itch happens. Which I don't know if that's a saying in Australia, but the 7-year itch is like, you get really good at what you do. You might be a little bit bored. You're wondering, there's no creativity in your life. And I had a patient come in who I was very bonded with, and she was crying in my office because of a sexless marriage, loved her husband dearly, but was very distraught about the lack of sexual desire, any pain that might come up when attempted. And I'm handing her the box of Kleenex, and the lightning strikes my brain, and I didn't know how to help her. And so I started digging deep into like, does anybody know anything about female sexuality? Because in my training, I was told women are difficult, they take too long, we'll never figure them out, and don't worry, the gynecologists are taking care of them anyways. All things I was told. And so I just started challenging
And
that.
they told you that, and you're a woman. Imagine what they tell the guys.
Well, exactly, right? And so I just started digging deep into sexuality and female sexuality and realizing we actually have a lot of data, but it's not what Hollywood says sex is. It's not what, our partners say sex is. And so it goes against the standard societal script of how you're supposed to behave, how desire is supposed to happen. And so I just was like, I want to create I love podcasts. And I'm like, I want to create a podcast looking at female sexuality in education, because I think so much of why we suffer is because we didn't get education in the first place. And we possibly got a disease and pregnancy prevention plan if we were lucky, but we did not get education on how pleasure works, how our bodies work, how to communicate. And so
what to call the parts.
So the fact that you have a 14-year-old in your car and you're open to saying, we all got here because of sex. We're all here because of sex. This is a common human experience. And the more we talk about it, we realize I didn't die talking about this. And in fact, I want to talk about this. And people actually love being able to talk about it because it's how our bodies work. So then I always joke, sex got me into menopause, because people kept saying, well, but you know what happens to your sex life with menopause. And they kept repeating it. And I was like, well, what does happen? And then I looked into the role of estrogen and testosterone and certainly pelvic hormones. And then I saw all the fear. We're so afraid of hormones. Why are we afraid of hormones? Where did that come from? So started looking into that data. And so it's just been quite the journey. The podcast is now 5 years old.
And the podcast is called You're Not Broken.
You Are Not Broken.
And I love that name for the podcast, because I think that is kind of the script that runs in a lot of women's heads when sex falls off, whether it's a lack of desire or discomfort or mechanical issues, whatever it might be. And in one of your podcasts that I really loved and I didn't know was about prolapse. And like when something as devastating as that happens, I think one of your guests who said that, or you talked about the woman got rushed to emergency because they didn't know what it was. So just having these conversations is just so profound, to know that you're not broken. And your book of the same name, it's a fun read, actually.
Thank you.
Because it tackles a lot of like really serious and sometimes devastating topics, but in that, forthright, let's just talk about it.
Yeah. Let's just talk about it. And so many people feel so empowered afterwards to be like, isn't it interesting that our default is to feel broken instead of to feel like maybe I don't have the education that I should have, right? And so to realize like, hey, let me just share some things with you. And I think a stereotype that people put on the menopause of people who are advocating for hormones is that we just want everybody to be on hormones. And it's like, well, no, I actually don't care what you do, but I care deeply that you have the education and the knowledge to make the right decision for you and to make a decision out of facts and not out of fear.
One of the things that I really enjoyed about the So Hot Right Now conference that you spoke at, and by the way, you brought down the house. It was so funny. We
got some good laughs.
Yeah, we got some good laughs.
Yeah.
And it was so wonderful to hear 2,500 women just like really engage with your messaging. And I think that it's going to have such a ripple effect when you're in real life, when you're with people, and if you're listening to your podcast or reading your books. If all of us speak to 3 other women, whether it be our child, our mother, our sister, our aunt, or our friend, the ripple effect of being more open and asking more from the healthcare system and more from our bodies. But the thing that I really got out of it, and I'm so delighted to have you on the show, is that sexual health is a longevity conversation.
Yeah.
Because we're living longer.
Yeah.
And we're having often multiple relationships, sexual relationships in our lifetime. And often we're having new sexual relationships after menopause. So we're arriving and starting a relationship and intimacy after estrogen has potentially vanished and testosterone is down and progesterone levels need to be. So this conversation is really a longevity play.
It is. Yeah, I truly believe that hormones are part of female longevity, sexual health. We have more data in men just because
pleasure is part of longevity.
Just because we have more data in men, but sexual health is a marker of cardiovascular health. It's a marker of well-being, a marker of, confidence in our bodies. Like there's so many benefits of being intimate, of connecting with people, of communicating about challenging things, that I always say it's like the next level of personal growth. Like there's so much to be gained in learning about your own sexuality, in learning how to optimize, in learning how to communicate. And to learn about sex is just a lot more than exercise. It's this deeply spiritual, profound, transcendent experience. But we didn't get taught that. We got taught don't get pregnant and don't get diseases.
It's
right?
true.
And so there's like so much more. And the other interesting thing is, medical people like me, we work so much in saying, okay, you're broken, let's get you to functioning.
Yes.
We also need to talk about, okay, you're functioning well, let's get you to thriving.
Yeah, right.
And there's a whole nother world in sexuality of like, well, you don't have pain and you can have orgasms sometimes, but what about it's fantastic?
Yeah,
right?
like sexual Olympics. So you go from, as you said, fixing to optimizing to winning.
Yeah. And I think that part, I probably should spend more time talking about that part, because we spend so many times just kind of pulling people out of the river right now, because there's so many people that need to be pulled out of the river. But once we're having good sex, we can say, it's just like anything. You're working out, how do you optimize it? You have a healthy diet, but how do you optimize it? You're sleeping well, but how do you optimize it? There's this whole other realm in sexuality that's also has the same conversation.
I think one of the wonderful things about discussing sexuality when you are older or at midlife is that there's this, you talk about the give a fuck factor, for lack of a better word. Like you give zero fucks at a certain point, and you just want things to work and you want things to be great. And it's in the same way that, you have a preferred airline and a preferred hotel and a bed sheet that you like. You just want it all to work and to be comfortable and wonderful.
Yeah.
And you talk about sex in kind of in that language, which I think is really useful. But I want to take it back a step first and talk about your medical training of, what happens when it's not working well?
Yeah.
And what does a urologist do? And what are some of the things that we can take preventative steps to never get there?
Yeah. So urologists, just to define what urology is for people, urologists are surgeons. So we're surgeons of the genital urinary field, like bladder, scrotum, penis, kidneys, ureters, urethra, and then in women, that would be clitoris, labia, vagina. Not all urologists are trained in the female side. In America, only 10% of urologists are female.
Wow,
but
10%.
Yeah, and it doesn't mean just because you have a female surgeon that she actually takes an interest in female urology. So it kind of niches down pretty quickly. There's urologists that just take out prostates, right? So there's a lot of different subspecialties within urology. But by and large, universally, urologists are very comfortable with sexuality. We're the doctors who get penises hard. We're the doctors that do surgery for when erectile medications don't work, there's surgery to get the penis hard. So it's a group of people who are already very comfortable discussing sexuality as important, valid healthcare.
Yes.
And that's what translates over to the female side. Because one of my aha moments was, who's taking care of the women who are supposed to be sleeping with the people that we're all giving Viagra to?
Yeah, right.
And is this equality? And there are many wonderful gynecologists, but they're busy. They've got to take care of birth control, bleeding, pregnancy, hysterectomies, all of that. We can't expect them all to be experts in female sexuality. The other thing is there's simply not enough of them, right? But so many women go to their doctor, hit a wall, because remember, doctors didn't get trained about sexuality either. And the data is...
It sounds like doctors didn't get trained about a lot of things, because you guys all got up on stage and said, I had 4 hours training in menopause.
Yeah, all of us, yeah.
And now you are a specialist surgeon, like top of the food chain of the medical realm.
Yep.
And you're saying that you didn't get trained on this and you had to go out on after your whatever 12 years of study, then pursue additional study to become a specialist to advise your patients.
All of the big thought leaders in menopause right now, none of us got traditional training in this. So we all have this like profound story. It's either our own profound suffering or a patient's profound suffering. Like we all have an incredible story of how we got here.
It's true.
Because it's not the default training. I hope someday it will be the default training and we won't be these unique, specialists because women are 50% of the population. And if you live long enough, you're going to go through menopause. This isn't a niche. It isn't a specialty. Everybody should know about this.
Can you talk to us about what happens? You know, one of the chapters in your book, I think it's called Menopause is to Blame, or...
could it be menopause?
Could it be menopause?
Like yeah.
Let's talk about that. And then I'd love to talk about some other, like, there were so many factoids that I want to get to. I don't think we'll get to them all today, but I would really encourage you to listen to Dr. Kelly's podcast. It is outstanding, and so many amazing guests as well. But talk about menopause and sexual function and some of the things that happen to our bodies.
Yeah. So the biggest thing to know about, two biggest things. One is that desire can be affected by our hormone levels. Not always. Desire's complex, right? It's how we were raised. It's our relationship. It's our stress. It's our health. So desire's complex, but can be affected by declining estrogen and testosterone. Mm-hmm. Testosterone gets the stereotype as the hormone for desire, but estrogen plays a role both in male and female bodies, all bodies. So they're both important. So that's the first one with desire, that hormone levels can influence it. But the other bigger one is what we call genital urinary syndrome of menopause.
I'm so pleased you said it, because every time I go to say it, I stumble.
It's really a big long thing.
GSM.
But GSM. But it's the best way to describe it because it's genitals and it's urinary. Mm-hmm. It's a syndrome, means a constellation of things, and menopause means the reason why it's all happening. Yeah. So it's a good descriptor, except for the fact that it can start in perimenopause, mm-hmm. Which is also a thing. So it's not all encompassing, but it's a pretty good term. So when hormones go low, and many people don't even know that menopause is when hormones go low. They just think it's a hot flash and no periods.
That's true.
But a hot flash and no periods is actually a symptom of your hormones going low.
Got it.
So hormones go low, and then lots of things change in the pelvis. So bladder leakage, bladder frequency, getting up at night to urinate, urinary tract infections, pain with urination.
And what I love about this is that you're just flagging none of this is actually normal, and you don't have to live with it.
Right. Yeah. People always ask, is this normal? And I say common doesn't mean normal.
Yes.
Right. So, and then the genitals, dry vagina. People say, dry vagina. And I'm like, have you ever had dry eyes? Have you had a dry mouth? It's awful, mm-hmm. right? And just because people will blow that off is not important. Mm-hmm. So dry vagina, decreased arousal, decreased ability to orgasm, disappearance of the labia minora, shrinkage of the clitoris, tightening and pain with penetration of the vagina, because we need collagen, we need blood flow, we need elasticity in order for sexual touch to be comfortable. Mm-hmm. And estrogen and testosterone play an important role in collagen, blood flow, nerve function. And when those go low, our pelvis suffers.
So it could be menopause.
Yeah.
In answer to your question
yes.
posed in the book, it could be.
Yeah.
And you're not broken. And
Correct.
all you need to do is
replace what's missing.
And what's missing?
Missing is the hormones.
Right.
So we can replace estrogen, we can replace testosterone.
So systemic and also topical.
Yes. Yeah. They're both, for most people, both are options. And you can absolutely be on pelvic hormones mm-hmm. and systemic hormones at the exact same time. Many people are. And that's a myth that you can't be on vaginal estrogen if you're on a patch. That's a complete myth.
Great.
And that most everybody can be on vaginal hormones, what we call low dose hormones.
So I have taken the vaginal estrogen, which I think is amazing, but I genuinely believe in, every part of your body is worth looking after.
Yeah.
And the other thing that's just come out in Australia is a DHEA called Intrarosa.
Yeah.
Have you got that in the US?
Yeah, but our Intrarosa, same product.
Right.
It's like more than double the price than Australia.
Really?
Yeah. So I love DHEA. And so for people who don't know, DHEA, it's a little suppository, a prescription product, and it actually converts locally into estrogen and testosterone. It makes beautiful vulvas.
Well, I had an interview with Dr. Newsom saying that she thinks that's even better.
I completely agree, but the price in America is the problem.
It's prohibitive.
Yeah, so I can get a tube of vaginal estrogen for $14.
Right.
And that'll last 2 to 3 months. Mm-hmm. DHEA, 1 month supplies, at least $100.
Okay.
So to me, I'm like, if everything was cost equal, because remember, menopause might last for 40 years, right? This isn't just a 1-month treatment. This is like skin care for life. And so that adds up. So I'm always trying to be cost conscious in how can we get something that's so if vaginal estrogen works for most people, it's my go-to. But if price was meaningless, DHEA is beautiful.
Amazing. Yeah. And so we talked about that. You talked about that a lot. But the other thing that you talked about is some of the things that we can take agency over. And that was lube. And you talk about I
love lube.
Talk to us about lube. Because a lot of people have probably not used it and don't know how to use it. And why it's so helpful. Well,
so I'm making this up as I'm going along, but I'm like, brushing your teeth, just the act of brushing your teeth is all you need to keep teeth clean. But toothpaste certainly is nice, right? You don't have a dry brush going in there and there's more moisture. And so it's like relying on our body, especially an aging body that produces less moisture, to be all for sexual health. I always joke, like, don't put all the pressure on the vagina to provide all the lubrication. The clitoris doesn't lubricate itself. The penis doesn't lubricate itself. Help the vagina out. And also, the amount of moisture isn't correlated to how much you desire sex or how much you're liking sex. It has no meaning to that. And so many people say, well, my boyfriend says I shouldn't need lube because that means I'm not interested in him or I'm not interested in sex. It's like, it just makes it better. It makes it absolutely better. So really to normalize lube as using it all the time, 20-year-olds should use lube. The other big problem I see is that women often put something in their vagina before they're aroused. I want everybody to stop doing that. But certainly if that's what's happening, you absolutely need lube because you haven't warmed up the pelvis. It engorged your pelvic structures. We need the pelvis to know that sex is about to happen. When a woman is aroused, her vagina actually lengthens and the uterus tips back because it can be painful to put pressure on the cervix.
I have a great update to share from Melrose Future Lab. Hormonal health is a vital hallmark of aging and longevity. And whether you're navigating perimenopause or menopause, Melrose Future Lab's new ultra-complex supplements are here to support you. Backed by clinical research and using advanced technology for effective absorption, these formulations are designed to provide relief through every phase. Find them exclusively at Chemist Warehouse. Always read the label and follow the directions for use.
So a lot of women, again, because we didn't get good sex ed, they're putting something in the vagina before their body is ready to do that. So I want everybody to stop doing that. But especially for those women, if you're going to do that, you better have lube involved because you haven't warmed up your pelvis properly.
You talked about sex toys on stage and also in your podcast. You talk about it a lot. And I guess that for women who are perhaps single or with a partner, what is the health benefits that you advocate? Because you talk about it from almost a medical perspective. Like, you've got to get involved.
I got to normalize it that way.
You've got to get involved.
I joke that I have 2 vibrators for my mouth. So I use an electric toothbrush and I use a water pick, right? Because technology designed specifically for the task is often better than just this old toothbrush that we used to use, right? And so I use that to normalize. We have technology everywhere. We drive cars. We have computers, we have phones, we have computers in our pocket. And then sex is that one area where we don't want to have any technology. It's actually kind of a crazy bias, right? But vibrators are developed specifically to help people have pleasure, blood flow, and orgasm. And the newer research on vibrators is showing the role of improving blood flow to the pelvis, which helps with arousal, it helps with moisture, and it certainly just kind of helps get the job done. 70% of women will not orgasm by putting something in their vagina, most commonly a penis. That's normal. That's anatomy. Again, we didn't learn that in our disease and pregnancy prevention plan, but so many women feel inherently broken because they don't orgasm the way they're watching Hollywood orgasm or the way they think they should orgasm. So bringing in the vibrator to say, why don't we work on your pleasure first, prioritize it, then share yourself with a partner that prefers to have an orgasm that way. But don't think that a penis was specifically designed solely to do the only job of bringing you pleasure.
What do you think is the thing that most women are missing in self-advocacy when it comes to pleasure?
Speaking up, communication. prioritizing their own health. So if you look at what they call the orgasm gap, and they've been doing this research for a long time. Sadly, the orgasm gap is not narrowing. So the orgasm gap is the rate of orgasm between a partnered couple. So they look at same sex and they look at heterosexual. So in heterosexual couples, the male has the highest rate of orgasm. Heterosexual male actually orgasms more than the same sex male and the same sex female when partnered, because his orgasm is prioritized, society-wise speaking.
And the partner often prioritizes his satisfaction.
Exactly.
Yeah.
So he clocks in around 95% of the time. She clocks in around 60% of the time as far as orgasm, and that's way worse with hookup sex. So the more invested the partner is, the more invested the partner who knows and cares about her pleasure, her orgasm rate goes up. And that orgasm gap is not getting better with time.
You talked about pornography and the role of misinformation from pornography. And I'm wondering if you could talk about that when it comes to sex in midlife and beyond.
Yeah.
Because, Gen Xers, we grew up at a time where there wasn't pornography on your phone. So you could literally be at checkout and get porn on your phone. If you wanted it, you had to buy a magazine that was often passed from, brother to cousin to whatever. Yep. So it's so pervasive. It's everywhere. We're meeting men who are, consuming an enormous amount of pornography. As you were saying, Hollywood culture portrays sex and intimacy in a completely different way. What do you see in your clinical practice and in the guests that you speak to as well about the role of pornography and pleasure and also anatomical misunderstanding of our bodies? Yeah.
So porn is pervasive. I don't think it's going away. I don't see anybody banning it. The video over internet was literally designed to deliver porn. Yeah. A massive amount of the bandwidth is for pornographic material. Like it is actually huge for people who don't know that what's happening. One of the biggest problems is people don't know that it's a performance. They don't know that there's multiple takes and things are augmented, and there's certainly a lot of lube happening. And women aren't often portrayed in the way that orgasm naturally happens for them. So the literacy, what they call porn literacy, is understanding, if you choose to watch this, understand it's produced to be performative and to maximally turn on the male brain. So it's a production. Is the greatest example is, it's like watching the movies The Fast and the Furious, and thinking that's how cars are driven, right? It is not real life.
Yeah. Okay.
So people need to understand that. Also, what porn can do is it's a huge dopamine rush, right? It's such an incredible dopamine rush that it kind of can be distracting from real life and wanting to connect and getting and understanding what sex is. It's so much more than just a dopamine rush for people. So it's used like sugar is used and drugs are used. It's like, it's for an absolute dopamine hook, and it's not real life. But the problem is, and we see this more in the younger generations because they just have access to porn a lot more than we had growing up, is them thinking that is normal.
And they're not discussing UTIs and, safe sex and lube and everything in any of these produced films either.
No. They're movies.
Yeah.
Yeah, they're movies. And that's why, Cindy Gallup, who's making the amazing thing, Make Love Not Porn, was realizing people were performing in real life like porn, and it doesn't actually serve people and it doesn't actually please the woman. And so she said, okay, we need to work on sex education better to kind of counteract the fake sex education that porn is providing.
So the other thing that I have a question for you from your urologist perspective is, do you get people in your practice and that you speak to that have a distorted view of what their anatomy should look like and what it should do? Because if you are on any of the platforms and you have, for example, there's a lot of sex workers that are now producing a lot of content. One of the most popular social media icons in Australia is a sex worker, and so she's talking a lot about what her body can do, some of the performative aspects of sex. And then, a normal person is in the bedroom and she's like, well, I don't look like that. I don't recognize my vulva as being able to perform these feats of circus-like athleticism. Do you get those questions in your office? Like, do people say, what is it? What am I meant to be doing? I don't have multiple orgasms. I don't do this. I don't do that. Do you have those questions?
Yeah. I mean, I think more now than even 2 decades ago, the comparison we're doing with performative sex is we didn't used to have the video. We didn't used to have the social media. And now we're comparing and despairing, right? Of who's allowed to have an orgasm, what's the right way to do it, how fast should you do it? You know, all of this stuff. It's like, guys, that's not what sex is. That's a performance sport. Let's talk about what sex is. It's uniquely personal. It's uniquely connected when you're with a partner. It's uniquely yours, right? And you comparing yourself.
Messy.
And uniquely messy, right? If I spend my entire life wishing I lived up to what an Olympic sprinter can do, I'm going to be constantly judging myself for my lack of success with running, right? And realize, like, break that. This is your exercise routine. This is your sex. This is your connection. So it's really important that you bring that up. What I like to do a lot in my office is normal body checks. So people come in and they're usually apologetic. Women way more than men, but men have the pressure too. But incredibly apologetic. I had a woman who came in, we were doing an exam for some urology issue. She was very apologetic. I'm so sorry that you have to look, and I'm so and she had a loving partner with her. And I said, listen, I look at 1,000 vulvas. I've seen everything. And vulvas are on a bell-shaped curve of what normal is. But you don't know that. You can't go online and see if you're normal, right? Because
And also, you know, you're not often on the receiving end of vulva pics.
Yeah. Yes.
So we don't compare and contrast.
Exactly. So I told the woman, I said, let me do an exam and I'll tell you where you fit on the bell curve of vulvas. And I said, you're completely normal, completely average, right in the middle of the bell curve, completely forgettable. I will never be remembering your vulva, right? And just reassuring her, like, you're completely normal, right? And the husband was so loving. He's like, honey, I've been telling you this. I've been telling you that you're normal and it's beautiful and it's lovely. He was so sweet. And she was carrying around her ex-husband's comment about how he said that she wasn't normal looking. And she carried that with her for decades.
Of course, we always carry the criticism.
You carry the crap.
You know, 100 people say you have beautiful blue eyes and someone says to you, oh,
I know.
You're not a brown-eyed girl, and it's all you can remember. So
our brains are wired for negativity. One person told me they didn't like my hair, and I'm like, oh, but I'm like, I like my hair, and lots of people like my hair.
It's iconic.
But it's like, not everybody, you know. Yeah. And first of all, just keep your mouth shut if you don't have something nice to say, right? But especially about profoundly sensitive structures.
So the next thing I wanted to ask you is about the way vulvas look. And there's been a lot of conversation and debate about labiaplasty and cosmetic or functional treatments.
Yeah.
In Australia, I think they've just recently banned a lot of the lasers. And also, I think 2 years ago, they banned the O-shot, which is a PRP.
Yeah, I didn't know they banned it. Wow.
They didn't.
Because of lack of evidence?
So what they did is they changed the insurance levy for doctors that were performing the O-shot. And for people who are listening and haven't heard of an O-shot before, it's PRP, right? Yeah. For an internal PRP and to the clitoris.
Yeah, periclitoral. It's proprietary.
Right.
Their injections.
Okay.
Yes. And proprietary locations.
And what it does is improve sensitivity and your ability.
That's the claim.
Okay. All right. Well, they raised the insurance level, so it became extremely expensive to be a doctor that performed O-shots. And then this year, they banned a lot of lasers that were doing internal laser rejuvenation.
Can women still pay cash?
I think no. I think the lasers or the claims that they're allowed to make is only for urinary incontinence, no longer for tightening or pleasure.
Yeah.
And then there's, of course, the most controversial of all, which is the labiaplasty, which is considered primarily a cosmetic treatment, a surgery. Yeah. But it can also be used for functional benefits. Can you talk to that?
So it's very interesting. It's very complex. There are some conditions of the labia where it's painful to ride a bike. The external labia might get pulled in with intimacy and pull and tug. So there are some very legitimate reasons to have things augmented a little bit. But because there's such huge profit involved, this is cash in America, no insurance covers this.
Oh, really?
That's not true. Insurance will cover it for a medical reason.
Okay.
So I can get it covered by insurance for a medical reason. But just because you want to look differently, they're not, for cosmetics, it's not covered. So because women don't have an education, because women aren't able to go on the internet and see what normal labia is. And this is a problem even for Instagram, Meta, like to be banned. If the sex educators are trying to say, let's teach people what normal is.
And use the normal words.
And use the normal words.
And not euphemisms and exactly.
Oh, the eggplant emojis. I'm so sick of the eggplant and spelling sex with S-E-G-G-S.
Well, there's no vagina or vulva emoji. There's no equivalent.
No.
What are we going to use?
We use peaches.
No, that's for the bottom.
Oh, I don't know. So anyways, but there's no knowledge. It's a lack of education. So women think that men want this. Women think that that's what normal is. So I truly believe women are being preyed upon by their ignorance, by their body insecurity, by feeling that they need to perform, that they need to look a certain way. And there are significant risks, not just the fact that you're going to empty your wallet to get this done, but these are nerve endings. These are erectile tissues, especially the labiaplasties that go all the way up and cut off the clitoral hood. Like, I cringe when women are told that that is what they need to look like. And for people to call it things like the Barbie, when the Barbie doll was literally created to be asexual, like there's breasts, but there's no genitals, right? And that women would think that that's the definition of what a woman should look like. It's insane. The other complete irony is premenopausal women are cutting off their labias. Then postmenopausal women are horrified that their labias disappear with low hormones. Right. And I'm like, you guys need to talk to each other. Right?
Look to the future, girls.
Yeah. Like we want to preserve labial structures. So I'd say there is a medical reason for some labiaplasties. I don't think we should ban it completely.
What if you want it? I mean, you talk a lot about agency.
Yeah.
So if you do want it, are there any kind of caveats? Do you have any advice for someone who wants it just for a cosmetic reason?
Yeah. So, and that's a valid point. You know, it's a valid point. But I want her to want it because of education. Not because of fear or thinking she's not living up to some beauty standard.
Sure.
Right. Go to a high volume surgeon who has great experience, who won't go too high around the clitoris, who understands the role of clitoral nerves in orgasm. Right. And that would be the best, is high volume, highly educated. That's your best bet.
I also want to talk to you about one of the things that you advocate for the most is the psychological aspect of libido, desire, sexual health. And if you could talk about what we can do from a midlife perspective again, because, you know, when we're young, there's this expectation that there's a lot of desire, there's the not being expert at it is okay. And then you get to midlife and beyond, and there's a certain expectancy that we're experts at everything, right?
Yep.
And then there's the deflation of not feeling confident, not feeling like you know everything about your body. What are some of the things that you speak to about the mental aspect of good sexual wellness?
Yeah. I think what we need to talk about more is the self-objectification that women do. And what I mean by that is we're constantly judging ourselves based upon the information we're gathering from the world. Fully understanding the information in the world is there to make you feel inferior, to make you buy products, to make you feel like the not confident woman who wants to go do whatever she wants to do. So I want women to say, like, do you actually think that way about yourself, or have you been trained to think that way about yourself? And the stereotype that women become less sexual is absolute bullshit. I mean, the amount of women when I talk about, like, not all women have low desire in midlife. And women are like, thank you so much. I actually have high desire. I don't feel like I'm being represented. I feel like I'm broken because people say I'm supposed to have low desire.
Wow.
So it's really representing those high desire women to be like, they exist. Women aren't all low desire in this world. And then as far as orgasm, a very interesting piece of data is the most important factor in a woman's orgasm is her knowledge of her body combined with the knowledge of her partner's knowledge about her knowledge. So that ties in, we need not only education on the behalf of a woman, what makes you orgasm? That's what you should do to have an orgasm, right? And then communicating that with a loving, supportive partner who can validate and help that experience.
Talking about what you just said about everyone's normal is different. One of the, when I was telling people that I was speaking to you and they were so excited to have this conversation, a couple of them said to me, tell Dr. Kelly that I've had the best sex of my life post-midlife because I was confident, I was happy, I didn't care, it wasn't performative.
Yep.
And do you also get that?
Yeah. I mean, the best trip is I'll give a talk, I'll give a lecture, and then I'll see the woman the next morning at like breakfast or coffee, and she'll be like, I had the best sex of my life last night. And it's simply like permission, freedom, education, let go of the fucks of society saying like, you need to look this way, you need to perform this way, you have to have an orgasm this way, it has to be this fast. Get rid of it all, be in the present moment, be connected, feel what feels good to your body. It's not that hard. But you just have to clean up all this crap that you've been fed for decades and like have permission to be like, it's okay to let go, to not be in control, to not, know what's going to happen next. Like that's part of the amazing joy of sex. So it's like people can have better sex like that.
Yeah. Well, you just raised something that I had to speak to you about. Have you seen Baby Girl?
Not yet.
Okay. So that's feeds right into what you were saying, is to let go, not to have expectations, to experiment. But more than that, we had Baby Girl, we had, what was it? Goodbye Leo Grande with...
that's so good.
Such a great movie.
Such a good movie.
With Emma Thompson having this kind of sexual awakening in her, 60s?
Yeah.
And you have a whole new renaissance of women appearing on screen, like where we were saying they're never on screen, but this time appearing on screen, having a sexual moment, having a sexual life.
Yeah.
And I'm wondering if you think that that's also going to feed into more curiosity, more education, and more demand for better education as we see more of ourselves.
Yeah. And more permission. Yeah. Right? Like representation matters. Seeing yourself portrayed, that somebody you relate to matters. And I think, going back to the amazing Cindy Gallup, she was just on my podcast and we both love that episode. She says, we create the future. We decide what we want it to be. It's not other people that are deciding what your sexuality is going to be like. And it's really that empowerment and that permission that you need. I had this couple come in, they were like late 40s. They both came in and they said, well, if you just tell us today that we're too old to have a great sex life, like we can accept that. We'll be okay with that. And I'm like, literally 2 hours ago, I had people in their 70s in here. They have sex 3 times a week. Yes, he's on Viagra. Yes, they're both on hormones.
It makes me think of Meet the Fockers.
Yeah.
With Barbara Streisand. Yeah. And that was such a great movie.
Such a great movie.
Yeah.
But it's like the stereotype of like, they just think that, 48 is too old to have great sex. And I'm like, these people in their 70s actually were not having great sex in their 40s. They were busy with their careers. They were raising children. They weren't empowered with their sexual health education that they have. Now that they're in their 70s, they have time. They're more connected than ever. They prioritize that in their relationship and they're having the time of their lives. And that representation matters. People don't know that that's a thing.
Yeah, that's true. You talked a lot about testosterone, and I would love for you to give us a 101 on the power of testosterone in the whole GSM conversation.
Yeah. So I always have to start with education because otherwise I'm this like crazy American urologist who's like, women should take testosterone. Yeah. And people don't know that it's naturally in women's bodies.
Have you had pushback on it?
No. Great. I mean, I've had a little pushback from, I think, people who are very happy with the status quo.
Okay.
Right? But other than that, like women...
I brought my testosterone to show you.
Australia is ahead of the curve.
Yeah, this was amazing.
The first country in the world with a government-approved testosterone product for women.
Here?
Yeah.
Really?
Australia's the groundbreakers. So testosterone is produced in the ovaries. Women have 4 times the amount of testosterone in their bodies than estrogen. We've stereotyped hormones. We've said men have testosterone, women have estrogen. That's not true. We just have them in different amounts. And so testosterone actually starts going down slowly after your 20s. So it's true when people say there's no cliff drop that happens with menopause. Menopause being the 1 year after no natural periods. Testosterone does not drop off a cliff. It's just a slow, gradual decline from our 20s. Profoundly can affect desire. libido.
So apparently that's the only thing you can get it prescribed for.
Yeah.
That you have to say that I have low libido. You can't just go in and say, I want it for brain health, I want it for heart health, I want it for bone health.
Right.
You
So
have to complain.
so the way medicine works is medications get approved for an indication.
Got it.
And what that means is there's enough research done for that indication. So that's where the libido comes from. But I hear from many Australians that they go in and lie to their doctor to get their testosterone, which breaks my heart. Because the doctor-patient relationship is supposed to be incredibly precious and incredibly, trusting.
But it's also very short. And in all countries, we hear this. Often it's so fast and transactional. You don't have time to sit down with your GP. Right. I love my GP.
Yeah.
But I really had to do a song and dance to get my testosterone.
Yeah.
And I had to have a really long consult for her to tell me all the reasons why maybe I shouldn't.
And you're like, I already have my education. I mean, and that's what speaks to the power of social media and the power of Instagram and the power of podcasts is the doctor visit is too short to get your education there. And your doctor might not actually be the most educated about a topic. So to get your education outside and to kind of learn about it and to understand it and then to come in and be like, this is what I would like to try. Let's schedule a 3-month follow-up. We can adjust the doses and I'll let you know how I'm doing. That is the best thing you can do when you're speaking. So for tips for people to speaking with your doctor, I've been reading a lot about X. I would like to try it because of this reason. I will schedule a follow-up appointment to let you know how I'm doing and to adjust the doses needed. That's how you talk to doctors.
That is such good advice. The other thing that I learned from you, which I was guilty of not doing, is that you have to use it daily. It's not a...
so it's not a systemic.
Exactly.
Yeah, so for systemic testosterone, the way this is dosed is it will be out of your body in a day.
Yes.
So it is a daily dose to have it be
consistent. Because you don't want to have
consistent.
up and then down.
Yeah, you just might not get the full benefits of it. But the other thing I want to talk about as far as libido and it being stereotyped that it's only for libido is testosterone works everywhere in the brain. And that's how it helps libido. And libido is a mood. So if it's true that we have good data that testosterone helps libido, it's also true we have data that testosterone helps mood because libido is a mood.
Got it.
So because people are like, it's only for libido. And I'm like, there's not a square centimeter in your brain that's only for libido. Libido is a mood. It's energy. It's how you feel. It's, your body feeling well enough for your body to be like, sex could be interesting, right? And so it's like kind of this exceptionalism that it's only for libido doesn't actually make sense when you know neuroscience and you know how the brain works and you know how testosterone is a brain neurohormone. You had brought it up earlier, so I want people to know testosterone can take a while to help affect libido. Often people will say the studies do show it happening quicker, but that they tend to be higher doses in studies. But so for the standard dose, 4 to 6 months for libido to kick in?
I reckon it took about 3 months for me. Yeah. But I did notice earlier that, I don't know if this is, psychosomatic, but I thought that I had less brain fog.
Yeah.
And I felt like I had better focus.
Yeah.
Would that be correct?
Yes, many women
And
say
I also noticed that if I forget to put it on in the morning and I do it at night, it can interrupt my sleep. It gives me energy.
Yeah. Yes.
Is that true?
Yes. Yeah.
Right.
Some people like testosterone at night that it helps them sleep. And then some people will find that it doesn't help them
sleep.
sleep.
It makes me like a bit energized.
Yeah, so it's different for everybody. But I always joke that when I give women testosterone, nobody comes back and says, it's only helping libido. Yeah. Nobody ever says that because libido's not an isolated, it's light switch. It's always like, and the crazy things women say with this, like it's, once doctors start giving women testosterone and talking to them afterwards, like the profound improvement in their life. I feel like myself. I feel like I'm 28. I can do math better. I had sex all weekend. The world went from black and white to technicolor. I can think faster. I'm more curious. My husband says I'm asking more questions. My friends say I'm not so negative anymore. Wow. Those are all things that people say about testosterone. I sound a little bit like it's going to help everybody. It doesn't help everybody. Like it's for libido, it doesn't help everybody. So I do want to say like, this isn't for everybody. I don't want to, sell magic snake oil here, but testosterone.
It's pretty good.
I know, but it's pretty good. It's incredibly safe, especially when dosed at female doses. And it just tells you that testosterone is natural in women's bodies. When we just give them back what they previously had, they love it. they don't want to stop.
And we don't want to stop.
We don't want to stop.
Dr. Kelly, where can we get more of your information? I know that you've got a private group, a subscription model with like some spicier and more in-depth podcasts and some great education content.
Yeah. I'm basically available everywhere except for TikTok because I finally was like, I don't like TikTok.
Well, but lucky we're at Meta. So
I know, lucky we're at Meta.
Music to their ears.
Exactly. Instagram is Kelly Casperson MD. The website's kellycaspersonmd.com. I have a Substack for people who like writing. The podcast is called You Are Not Broken. The book is called You Are Not Broken. And the second book's coming out in September.
Yes.
It is all about, it's profoundly unapologetic about the benefits of hormones because I just felt like that was the book that needed to be written.
Amazing. Now, did I hear that you had closed your clinical practice?
Yeah.
Tell me about that, and then we'll wrap. And I'll let you enjoy this Sydney day while you're.
So I'm a surgeon. I've done traditional medical practice in the United States. I saw 25 patients a day. It was a grind. Everybody just wanted more. And insurance being what it is in America, it's incredibly challenging to deal with. The doctors no longer practice medicine. The businesses practice medicine. So I want it out. I want connection. I want time. I want to love. And I want, at a minimum, an hour-long appointment with people. The most validating thing for a woman is to say, I feel seen, I feel heard, and I have a partner who's going to help me on this journey.
Yeah.
That's the medical clinic I'm creating.
Absolutely wonderful to see you. I'm so delighted. I can't believe it that I'm in the same room as you. I've been following you for so long, but I'm so thrilled to have heard you speak. It's so hot right now to be here at the Meta Studios to record with you today. And I really can't wait to see how the ripple effect of your presentation in Sydney went. And please come back.
I'm excited too.
We want you back.
Thank you very much.
Thank you so much.
Thanks for having me.
Thanks for listening. If you enjoyed this episode, please subscribe to the channel, sign up for our free newsletter, and consider leaving a review and rating it. This really helps the channel grow and reach new audiences.